I'll finish up with just a note about advances. I don't think there's going to be much advance in mechanical valves in valve design. I mean, we've gone about as far as we're going to go. There's no company that's going to invest a lot of money in the mechanical valve market in terms of valve design. But there are advances in managing patients with mechanical valves, and I'll just go over a couple of those quickly before we end. And the first, and everybody's aware of this, is low-intensity anticoagulation for bioprosthesis. There's new antiplatelet drugs, and there's patient self-testing. I'm going to go through this quickly because I think you're all familiar with this. I want to get into the patient self-testing and the new drugs. Patient self-testing is dose management by the physician, but the patient testing themselves, and then patient self-management is like diabetics who decide how much insulin they take based on what the blood sugar is, and both of these are available nowadays. In fact, the Europeans are way ahead of us with patient self-testing and self-management. And the devices that are used are just like they use for glucose. They're little these INR measuring machines have. They look kind of like a TV remote control. You take a finger stick, you put it in the machine, and it gives you an INR. They're point-of-care instruments, and there's another one. They use lots of different techniques for clot detection. And what all of the studies of these have shown is that you can improve the time in the therapeutic range by using patient self-testing over usual care. And this is just one study. There's 50 of them that show that if you have the patient do self-testing, and self-testing usually is once a week, usual care is 1 INR a month, you improve the time in the therapeutic ratio. Now, the time in the therapeutic ratio is not one of those things that's going to get you on the plenary session of the ACC. I mean, that's just not one of those real exciting things. But it's very important because it reduces the risk of thromboembolic complications. As you can see here in this particular study, you reduce major bleeds by about half, and you reduce recurrent venous thromboembolism, which is what this study was about. This is another study that looked at the time in range with usual care. About 50% of patients were in range, and you can increase that to about almost 90% with patient self-testing. So that's very important. And then this is another study that looked at usual care and patient self-management, and you can increase the time in a therapeutic range from about 60% to almost 80%, and you reduce total events from 4.7% to 2.9. Now, this is the one that I want you to look at because it looks at usual care and self-testing. This was a group of patients that had valves in, so these are all mechanical valve patients. And if you use patient self-testing, you can reduce the thromboembolic complication rate from 3.6% to a little less than 1%, and you reduce bleeding complications from 11% to 4.5%. Now, I've shown this slide at a lot of surgical meetings, or a number of surgical meetings, and it just doesn't generate the kind of oomph that you'd want. So I decided to change it, and I changed it from usual care and self-testing to your valve and my valve. And if a manufacturer had a valve that reduced thromboembolic complications by half and reduced bleeding complications by half, you'd grab some market share. I mean, some serious market share. But all you have to do is change the way that you manage patients. And so I think we believe in cardiac surgery that it's very important to use patient self-testing. And it's interesting, at least up until about 3 years ago, 60% of clinics in the United States prohibited self-testing, mainly because I think there's some financial incentive to keep the patients coming back to your clinic. And at that time, only 1% of the patients in the United States used patient self-testing. We've used it here for a while, and in fact, we did a study. The very first study that we did in cardiac surgical patients was to see whether you could learn self-testing in the hospital early after surgery. That's a time when their patients are getting narcotics, are a little fuzzy from the operation, and the question is, can you teach somebody self-testing in that perioperative period where you're trying to, everybody's trying to get the patients out of the hospital as quickly as possible. You're trying to make sure they're recovering well. You're trying to give them enough pain medicine. But to be fair, the diabetologists teach somebody how to use insulin in about 48 hours, so we thought we could do it with patient self-testing. And in this particular study, we started the patients at about the second or third day, taught them how to use the meter, how to record the INRs and so forth. And there was a very good correlation between the lab tests at Mayo, the INR ratio, which is this patient self-testing device, and their MD's recording of the INR. And of the 50 patients that we used this on, all of them were able to continue self-testing at a month. There was only one patient that wasn't self-testing, and that patient was a patient at the Mayo Clinic, and their physician told them to stop doing it. So that was the only patient who wasn't self-testing at the end of the study. Well, the future is new drugs, and I did have some material on dabigatran, but I think everybody in the room is probably familiar with dabigatran. When we talk about the possibility of valve in a valve for bioprosthesis, everybody's heard about that. That if a bioprosthesis fails, now we have percutaneous valves, you can put a valve inside the valve. I've had patients come into the office and say they wanted a bioprosthesis because in the future they won't have to have the valve replaced, they can just have it put in percutaneously. I think it's also fair to point out that with mechanical valves, I suspect it is very unlikely we'll be using mechanical valves. I mean, we'll be using Coumadin in the next 5 years. Dabigatran almost certainly is to be approved, if not this calendar year, for sure in 2011. And I doubt that there's going to be any patient on Coumadin, and that will also improve the outcome of patients with mechanical valves. So anyway, I'll stop at this point.